We're very pleased to introduce today Dr. Nada Fadl. She is a distinguished leader in medicine, currently serving as Associate Dean for Faculty Affairs and Professor of Medicine at the University of Nebraska Medical Center in the Division of Infectious Diseases. She is also the Medical Director of the UNMC, the University of Nebraska Medical Center, Specialty Care Center, and the Principal Investigator of the Ryan White Part C and D grants. She is a graduate of the University of Khartoum, Faculty of Medicine in Sudan. Dr. Fadl continued her training in the United States, completing her internal medicine residency at the University of Illinois in Champaign, Illinois, and followed by clinical fellowship in palliative care at MD Anderson Cancer Center, and then infectious diseases fellowship at the University of Texas Health Science Center in Houston, Texas. Dr. Fadl is widely published, has presented her research on HIV and AIDS at national and international forums, and is deeply committed to addressing health and disparities and quality of life issues in this population. She is a board member and of the awards committee, an awards committee chair of the National HIV Medical Association, and a recent graduate of the prestigious Executive Leadership in Academic Medicine, ELAM program. Beyond her professional roles, Dr. Fadl is an active advocate for Sudanese and global health initiatives. She serves as the vice chair of the Sudanese American Public Affairs Association and the Association of Sudanese American Professors, and co-founded Sudan Next Gen and played a key role in the coalition of Sudanese organizations against COVID-19. Her dedication to mentoring, leadership, and advocacy makes her a vital voice in both academic medicine and global health. And also, not to mention that Nada is a vital part of starting this group and will continue to support. Now I leave the floor for Nada to introduce her talk today. Welcome, Nada.
شكرا عز الدين، شكرا كثير على الكايند introduction. طيب البرزنتيشن الليلة كنت حاجة عملتها في الريسيرش كونفرنس بتاعنا قبل شهر. Some of it might be a little redundant، لكن بس I wanted to shift gears شوية من topics, the scientific topics, and talk about other parts of being an academician, which is conducting research and addressing something that you're passionate about. يعني بالذات للناس الجونيور اللي لسه بادين الأكاديميك لايف بتاعته, and how to go about finding something that you feel like you're actually making you're contributing with a purpose للresearch world, ما حاجة بس just to publish papers and see the number of publications increasing in PubMed. طيب, a talk that I named it Implementing with a Purpose. My recent found passion is implementation science, and I'll talk a little bit about that and why did I switch to implementation science in the past couple of years or so. So without further ado, we'll talk a little bit about definitions. What is health disparity? Why is health disparity? Where is this implementation happening? بعد ذلك هنتكلم عن methods بتاعت implementation science, including quality improvement. Many people don't think about quality improvement as a method of implementation science, and it's a very nice niche and easy to implement للناس الشغالين في clinical world تحديداً إنه to conduct quality improvement type of work in a very scientific and methodological way. Just some disclosures. Part of this is going to discuss research that's funded by HRSA, CDC, AIDS United, and ViV, Gilead for the implementation science projects that I conducted. I always start my presentation with something from Sudan, يعني عشان أوري الناس إنه ethnicity بتاعتنا والbeauty بتاعنا is beyond what they hear in the media and the news. That Sudan has really beautiful cultural heritage, ethnic backgrounds. People can live in peace if they wanted and chose to, if their government does not interfere in deciding what their fate should be. يعني. Just a nice reminder for all of us يعني, to celebrate our heritage and culture, even in dark times like what we live right now in. طيب, health equity. What's health equity? The CDC defines health equity as when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. I think for all of us, being Sudanese, being from Africa, being darker skin, brown, black, whatever you want to call it, we have experienced some sort of health disparity, whether it's us, our family members, our children. When we take them to the doctor, you always just have that feeling that you're not getting the full treatment, the full respect, the full attention that everyone else who's from an advantaged background gets. It's something that we feel inside, but it's not really just a feeling, it's actual facts and it's driven by science. So equality basically is when you give everyone the same tool and expect them to attain the same potential, which is shown in this picture. I love this picture because it illustrates all of this in just a diagram. And then equity is when you customize the tools to people based on what their background and abilities are, so that you help them with those tools to attain the potential. And there is no reason why everyone should not get the same health care and the same access to health like everyone else, because health is basically a universal human right and should be treated as such. So health disparities do exist. In spite of everything that's been said and done, there's still significant health disparities that happen in groups of people. And because I live in the US, you're gonna hear a lot about US data when it comes to this, but there's also a lot of global disparities. So health disparities are preventable. And I wanted to underline that because they're truly preventable. They shouldn't happen. And there is difference in healthcare, but also health itself. So it's not just the health is different. It's not genetic most of the time. It's because of healthcare access and healthcare quality that people receive. That's why there are differences in outcomes. And they do limit the gains of the population. They affect everyone else because they're costly. When there are health disparities, when there are groups which are not healthy, it's actually very costly to the broader population, to the healthcare system. And you probably all know that the healthcare system in the US is the most expensive system in the world, yet we rank very low when it comes to the quality of health. And that's really driven by many factors, in addition to manufacturer, insurance, costs, and all of that. It's also driven by the fact there are significant health disparities. So groups like African American, Hispanic, etc., when they access the healthcare system, they cost a lot because they come in very late stages of diagnosis, whether it's heart disease, whether it's cancer, whether it's HIV. They're usually not able to access the healthcare system early on. So the other thing that I wanted to mention and emphasize is that we now have a lot of science and data showing us that race is not a biological construct. There are no genetic differences between Black people, white people, Asian people, Hispanic people. You continue naming that. 99.9999% of the genome is identical in all these groups. The differences are in the melanin, in the eye color, in very minor parts. They do not really amount to why health is different in these groups. And in fact, if you take a Black person in the US and you compare to the genome to a white person in the US, they're going to be closer than a Black person in the US with a Black person in Africa, because the environmental factors that they share here in the US are very similar. And that's what affects their health more than their background of color or where they came from originally. So race is really a social construct. It's often based on physical appearance, or skin color, on social factors, cultural factors, etc. So it shouldn't really determine health because, again, the genome is much more identical than what the race is. Also, race is a political construct. I tell people that when I came from Sudan, we don't have Black and white and Hispanic and all of these racial groups. We have other ethnicity groups, but when we moved here to the US, then you merge into this Black African American group and you're like, what? Who is this group? I'm not sure even whom I belong to. And many of us in the US, when we had to fill that first form of Social Security, that's when we were stuck by the fact that we're actually Black and we have to check that box. And then again, going back, race is not biological, so it doesn't make sense why race explains disparities. So what really amounts to is that race is tied to these social determinants of health. And these are things that are known nationally, globally, as things that impact healthcare and health outcomes. And this could include anything from access to food, to stress, to housing, to education, to language, to religious preferences, to neighborhood safety, lots of factors that play a part in those social determinants of health. And each one of them is linked to certain health outcomes. And a study that looked at the effect of social determinants of health versus individual behavior found that health behavior, which we talk to people all the time about. We spend all the time talking about tobacco cessation, diet, exercise, not drinking, sexual activity, etc., etc. All of these health behaviors amount for only 30% of health outcomes. But the other factors, socioeconomic factor, physical environment, healthcare, these amount to 70% of health outcomes. So we can try to influence health behavior, and we still need to do that. But that doesn't mean we should neglect the other factors and assume everything is a patient responsibility, because it's not. They're only responsible for 30% of their outcome. The community, the society, the organizations are responsible for the next 70%, which is the part that we're usually not actually addressing, not paying attention to. This is a very nice concept that kind of tells us that nothing is responsible by itself. There are intersectionality between all these factors that intersect with each other: education, with ethnicity, with hobbies, with physical health, with nationality. These things actually either add to each other positively or negatively, because somebody who's less educated, they're less likely to get an employment, they're less likely to have physical health, less likely to have insurance, et cetera, et cetera. So these things actually tend to build on each other, and that is what's called intersectionality. Now, I just wanted to stop and look at HIV for a moment, because that's a disease that has the highest disparities ever in the world, but also in our own state here in Nebraska. So in Nebraska, people living with HIV is about 2,400 people. We see more than half of them in the clinic at UNMC. And if you look at the distribution of that by race and ethnicity, you'll find that the majority of people living with HIV in the state are not white. So they're either Hispanic or Black. But the state of Nebraska, 90% of people in the state are white. So then you have more than 50% who are not white living with HIV, but the state demographics tells you all that group is less than 10%. And that's what disparity is. Like you can't compare the rate of the population with the rate of the disease. That happens also in HIV in sub-Saharan Africa. Only 12% of the population in general, the world population, lives in sub-Saharan Africa, but 70% of HIV cases happen in sub-Saharan Africa. And that's a huge disparity that's not explained by, genetics. It's explained by access to healthcare and access to resources. This diagram illustrates that very nicely, in that the rate of Black females living with HIV diagnosis is 24 times that is white females. Very huge disparity when it comes to race and gender, which are intersectional factors in this case. This is our population, and I just wanted to bring this up because a lot of my research is based in our clinical setting. So again, while the state is only 10% Black, we have 396, almost 30% of our patients are Black in the clinic. Same with Hispanic ethnicity. Hispanic or Latinos in the state are less than 10%, but they make about 30%, 25% of our patients in the clinic. So just a very huge disparity as well. We have a very large refugee population in the state of Nebraska. It's one of the big resettlement states. So you can see all the languages spoken in our clinic. They list Sudanese as a language. I always laugh at that because I'm like, what is Sudanese? There is no language called Sudanese. But Denka is here. We have Nuer as one of our languages. So we have a lot of languages from our region in the clinic. And we have a lot of disparities when it comes to housing. A lot of patients don't have housing. A lot of people live below the poverty margin. The poverty margin in the state is very low, like $14,000 a year or something. So if you can imagine people living below that, they can't really make anything. They can't really make ends meet. So we have 482 patients, 30% of our patients live below 100% poverty limit, making less than $14,000 a year or so. So then how do you translate that into equity? Like, then how do you do research about this to translate it? So you can study the reasons behind lack of equity. Why is this happening? What's the main driver of HIV incidence, HIV prevalence, HIV outcomes in this population? And then you can go on to implement programs to address those inequity factors. And then you could also work on improving equity in access to research. Many of the HIV studies do not represent the population that is affected by HIV. So manufacturers, big companies want these studies out, right? They want them to show good outcomes. So they tend to select populations they have higher access or better ability to adhere to research guidelines. And then that translates into excluding populations who are highly impacted. So many of the studies do not represent the Black and Hispanic populations that's impacted, and we need to work on that. And then, of course, training. I recently started working on implementation science in education, which is a really fascinating area. So we'll talk a little bit about that, what we're doing in Sudan right now. And then working beyond your neighborhood, working in a global fashion, that's really important. So COVID brought a lot of these inequities to surface. People before that did not like think about health equity or health disparity. 2020 was a major year where that became a factor. But in HIV, obviously, we were working on this long before COVID started. So one of our first publications that came on very early on during the pandemic was looking at structural vulnerability among patients with HIV and COVID co-infection. This was a descriptive care series. It was a very short, brief communication in AIDS care. And we looked at about 30-some patients who were diagnosed with COVID-19 who had HIV. And we found that the majority of these patients were not US citizens. Their occupation, being frontline in meat factories and other places, put them at risk for COVID-19. And their main language was not English, and they were from some other ethnicity or background. So the people who were impacted by COVID, unfortunately, in the beginning, and many of us here, Sudanese in the US, remember the New York population. The Sudanese population in New York was very highly hit early on because most of them work in daily living jobs, you know, whether it's a transportation, whether it's factory type of work, that puts them a lot of risk of COVID-19. Some of the newer studies that we looked at, there is a huge database called N3C. This is a database that's funded by NIH, and it collects EMR data, EPIC data from several institutions across the country. I think there is 70-some institutions that participate in this. And we participated in it looking at two main issues, which is the social determinants of health at the county level and at the individual level. And at both of those levels, we found that social determinants of health had a big impact on COVID-19 outcomes in people with HIV. So this is true even in people who have comorbidity and co-infection. In our own patient population, we looked at one of the social determinants of health, which is insurance status, and whether that is associated with health outcomes. Nebraska expanded Medicaid. For people outside of the US, this doesn't really make sense, but not everyone had insurance before 2020 in Nebraska. People who don't have income basically did not have insurance. If you're not able to pay for insurance, you didn't have it. And after Medicaid expansion, people with low income who make less than 138% of the federal poverty limit, which is about $16,000 a year, now they're able to get insurance funded by the government. And that was a huge, huge improvement compared to before, because people before that did not have any access to healthcare because of that. And once Medicaid expanded, you can see here in the graph to the left that before Medicaid, there were only 92 patients on Medicaid. After Medicaid expansion, 268 patients became funded by Medicaid. A lot of these patients came from ADAB, which is a program that funds people who are uninsured or people who do not have insurance at all. These are the two groups that became Medicaid funded, which was really what we wanted to see, that people became now funded by Medicaid before they had insurance. But interestingly, when we looked at outcomes, the black up here is, it doesn't show in the diagram, unfortunately, but it's retention in care. The red is viral suppression, and the blue is sustained viral suppression. When we looked at all of these outcomes, the only factor that determined all of these was poverty. So the one that crosses the line to the left is federal poverty limit less than 138%, had higher chance to not have retention in care, not be viral suppressed, and not have sustained viral suppression. This is the only factor that stood out. So even insurance, after insurance, people did not improve their healthcare outcomes because poverty still was the biggest driving factor. So this publication is now under consideration. It was presented at ID Week by one of our residents a couple of years ago. We also looked prospectively. We did a prospective study following these patients from the time of Medicaid expansion until 1 year after Medicaid expansion. And we asked them questions about healthcare utilization, access to medications, et cetera. And we did find that people now are able to get outpatient care after Medicaid expansion. So before Medicaid expansion, when we asked them how many times have you gotten care in ambulatory or outpatient setting, the odds were much lower before Medicaid expansion, and that improved significantly after Medicaid expansion. but did not change the emergency room visit or overnight hospital admission. This was presented at IAS conference, International AIDS Society conference. And we also asked them about access to medications, and we found that well, this is still about healthcare utilization. A lot of the factors improved, as you can see in the p-value, in terms of access to primary care, getting appointments when they need it, having to go to the ER if they don't have access to healthcare, that reduced, having to wait to seek appointment, that went down. Have you ended taking less medications? Because people used to take less medications than they were supposed to, because they have to ration their medications before Medicaid expansion, and that decreased from 30% to 7%. Had a routine checkup that increased from 45% to 66%. Difficulty paying for medication actually went down as well, which was really nice to see after Medicaid expansion. So there was some positive outcomes to Medicaid expansion when it comes to healthcare utilization of patients, but unfortunately, poverty still remained the biggest factor in determining outcomes of HIV, such as viral suppression, etc. So then moving from studying the disparity, because all of this that I presented to you is my work in studying disparities, studying factors that drive poor outcomes, etc. Moving on now to implementation science. And as I mentioned, this became my new passion because it doesn't only look at factors that impact the disparities, but it looks at solutions. What can we do? How can we implement evidence-based solutions to improve equity, to improve access to care, etc.? So Anthony Fauci, many of you know who he is, had published a piece in the Washington Post back in 2016, actually, saying no more excuses. We have the tools to end the HIV pandemic. And we do have the tools. We have prevention tools such as PrEP. We have post-exposure tools. We have treatment as prevention tools. If we control HIV in everyone, they're not going to transmit HIV to others. We have so many tools to end HIV, yet we're not even close to that, right? And the reason that is that we are not good at implementing evidence-based interventions that control HIV. So pre-exposure for prophylaxis, for example, that was approved in 2012. Now it's 2024, 12 years later, and the access to PrEP is very limited in populations who need pre-exposure prophylaxis. And the reason that happens is because of lack of the gap between evidence and implementation. And that's why actually implementation science became a field. It's a scientific study of methods and strategies that facilitate the uptake of evidence-based practices and research into regular use by practitioners and policymakers. So once we finish that randomized control trial and publish it in New England Journal of Medicine, it takes a few years for the guidelines to change. It's now quicker at changing, right? So they change maybe a year after. They say now PrEP is recommended, et cetera, et cetera. But then from there till the practitioners, the primary care doctors implemented, the average it takes is about 17 years. And that's why we're still not seeing it 14 years later. And the goal of implementation science is to shorten that duration, because if we implement it in an evidence-based way, just like we did research to study if this works, we do research to study how we can implement it. And that's basically what is called close the know to do gap. That's the goal of implementation science. This is a framework that is suggested by HRSA, the Health Resource Service Administration, part of the Ministry of Health here or Department of Health in the US, of how to implement things around HIV and how to study them. So basically you have the input, you have the intervention strategy, which in this case could be pre-exposure prophylaxis. The intervention is what the evidence-based intervention that showed to improve outcomes. So if we take PrEP, for example, as an intervention, that is our intervention strategy. Implementation strategy is how we implement this intervention. So it could be educating healthcare providers about PrEP. It could be educating patients about PrEP. It could be delivering PrEP at pharmacies, not at clinics. It could be collaborating with religious leaders so they can become champions of PrEP in their own religious settings. It could be a lot of things. These are the implementation strategies we're going to use depending on the setting we work in. Then the barriers and facilitators, we have to take into account organizational, contextual, individual barriers. So for example, if we're going to implement PrEP in a clinic, we have to think about transportation for patients, appointment reminders. We have to think about offering appointments after hours, all of these things in order to improve the barriers that patients bring to the table. And we have to study those barriers. We have to know what they are. We can't just assume these are the barriers. And then we look at implementation outcomes. So implementation outcomes are different than efficacy outcomes. When we look at efficacy outcomes, we look at whether PrEP works, for example, whether Biktarvy works, whether those are the evidence clinical outcomes that we look at. Implementation outcomes are different. We look at uptake of the intervention, engagement with the intervention, barriers and facilitators of the intervention. How did the implementation itself go? We interview healthcare providers, we interview patients, we do mixed method studies, surveys, etc., to figure out how the implementation outcomes went on. And then there are client level outcomes. This depends on the disease. Cardiovascular disease, you look at different client outcomes, but in HIV, for example, we look at viral suppression at one of the outcomes. We look at adherence to care as one of the outcomes that we think about. So this is a very nice framework that puts the inputs and the outputs together in this framework of implementation science in HIV. And this is what we use for a lot of our work around HIV. So this was back in North Carolina when I was there. We implemented a program in the emergency room to test for HIV. We had a very high incidence of HIV in the population there. We were missing a lot of cases. So these are the strategies that we implemented. We integrated testing in the normal flow of the emergency room. We changed the EHR. So the EHR would actually give you a prompt when the patient is triaged that says, this patient has never had an HIV test. Do you want to order a test now? And it gives the nurse the language that they should tell the patient because HIV does not require a consent anymore in the US. It just requires what we call opt-out testing. So the nurse can tell the patient, we're going to test you for HIV today, along with your troponin and all other labs we're doing. And unless the patient says no, then the nurse can go ahead and order it. So we changed the EHR to have that pop-up come up. It's a hard stop for the nurse. She has to acknowledge it, either order the test or decline, patient decline. And then we changed the policies, we trained the nurses, we trained the ER providers. We provided them assistance from the clinic. If the patient tests positive, then our clinic staff will take the lead in contacting the patient because the ER doctors did not want to do that. They're like, we're too busy to do this. And that all helped increase our testing numbers. So from 120 tests in 1 year, we went up to 9,000 tests in less than a year, which was extremely high compared to what we were before. So it's like 120 and now 9,000. We found that 62 patients tested positive for HIV. Interestingly, a good number of them, 58%, were previously positive, but they didn't tell the nurse at that time that they were previously positive. But many of them were actually not in care. So this was also an opportunity to bring them back to the healthcare system. And we had 26 newly diagnosed patients. And this is, again, in less than a year. This is in about 10 months or so. Lots of newly diagnosed patients, and we were able to link majority of them to HIV care, and almost 70% became virus suppressed in less than 3 months, which was amazing to see. Another program that we implemented here in our clinic is using telehealth to provide coaching for patients who are not doing well with HIV. So this is mostly addressing mental health and substance use disorder in our patients. People who have mental health, substance use disorder is the main reason they're not coming to their clinic and not taking their medication. We enroll them in this coaching program with a mental health counselor. They sit through 12 sessions, weekly sessions. Each session is about half an hour, so not very long. And these sessions address a lot of things. So we ask people, what do they want? We do questionnaires in the beginning, and we give them standard core sessions, and then we ask them what they want. And from there, we then deliver the sessions that they most likely need. And we found that actually this is the baseline demographic, so 29% of them were virus suppressed. And after implementing the program, viral suppression was 97%, which was amazing, from 29% to 97%. This is after a year of being in the program. So the other study that we looked at in terms of implementation science is what we call pre-implementation. So this is a study looking at long-acting injectables, which, as we know, is amazing new development in HIV world, but we're not able to implement it very easily. There's so many factors that play: insurance, prior authorization, patient transportation, etc. So we did a survey of clinics across the country. These are Ryan-White clinics, meaning they get federal funding. So they serve a pretty poor disadvantaged population. And we asked them about what their readiness for implementing long-acting injectables is. This was published last year or the year before, I can't remember. But the study was acceptability, feasibility, and appropriateness of implementation of long-acting injectables, a national survey of high and wide clinics. And interestingly, clinics were really excited about this in the beginning. So these are standardized questionnaires called AIM, IM, FIM. And you can see a lot of the clinics had very high ratings of how feasible, implementable, acceptable this is to them. But then one of the questions here, long-acting injectable seems easy to use. People did not rate that very highly. It was 66% of the clinics that said this is easy to use. This was pre-implementation. This was before the FDA approved it. We did another study right after, actually 2 years after FDA approval, and we followed up with clinics asking them the same questions, and we asked some other different questions. But now you can see the difference, like especially when it comes to feasibility, the FIM domain, a lot of the answers have changed now. So feasibility, easy to use, still remained low, but implementable went down. A lot of the other domains went down. Doable went down. So even though acceptability remained very high, appropriateness still remained very high, maybe even higher, but feasibility of implementation went down, which was really interesting to see. And this compares them kind of right hand to hand. So 2023 and 2021. So FIM, as you can see here, the full domain, summing all of these together, went down quite a bit compared to the pre-implementation questionnaire. And this is actually now being reviewed in the same journal, I think, Open Forum Infectious Diseases. So then the last study I'm going to talk about in HIV is something that we're actually implementing right now. We got funding from ViiV, the drug company, to implement this study. And this is basically implementing long-acting in rural population, because patients in rural population have to drive 2-3 hours to come to the clinic. So they used to come every 6 months, and now we're asking them to come every month or every 2 months to get the injections. So how about if we provide the injections locally to them in their own primary care clinics? It's a risky thing to do, but that's what implementation science is. You have to do it in a structured way. You have to train people. You have to measure outcomes. So this is what's called the PRISM conceptual framework. So it includes our implementation strategy, and it includes also what we're going to measure. The RE-AIM is a familiar framework in implementation science. It measures adoption, implementation, maintenance, reach, and effectiveness. So all of these, we have questionnaires, we have different interviews, qualitative, quantitative data that measures all of these factors. But here is our implementation strategy. We train project champions in our clinic and in other clinics. We're implementing telehealth as a way to reach these patients while they're getting their injection in the other clinic. And we're providing them case management through patient navigators. And we have a Project ECHO program running right now to train to train providers in the state around HIV testing, HIV treatment, cultural sensitivity for people with HIV. And we have team meetings. We meet every month, and we also meet periodically with people from other clinics to discuss what challenges and issues that they're going through. Now, if you think about these things, these are things we do every day almost. These are things that we usually do in our own practice, but we don't think about them as implementation science, right? Many times we do training programs, we do telehealth, we do team meetings. We do them routinely, but we don't really study if these are effective or not. We just assume that they're effective. But the beauty of implementation science is that you can actually study these, and you study which one is working compared to the others. So you can actually separate them. But you also study pre-implementation. Before you start implementing, you get the patient perspective, you get the organizational perspective. And based on that, you decide on your strategy, and you also decide on your outcomes. So even things that we do routinely daily, we can now study them in a structured way. So this is a schematic of the study. Pre-implementation, we assess these factors when it comes to patient, staff, etc. Implementation, this is what we're doing. I'm not going to go into detail. And this post-implementation is what we're doing. We're using what was called EPIS framework, which is a framework that goes on from the beginning till the end of the implementation. So the E is exploration, P is planning, I is implementation, and S is sustainment. So you basically have to go through all the phases until you get to sustainment of the intervention. You're studying it all the way until then. As you can see here, telehealth and text messaging is a very major part of what we're doing in our strategy. And we're doing a lot of surveys, interviews. We have a whole study team, like 4 people actually working on this study to collect all this data so we can figure out what's happening. Okay, so I'll take a break a few moments here before we switch gears, because this is all implementation science in HIV. But I want to talk a little bit more about implementation science in education, because for some of us, we're educators, we love education, and we implement educational programs and strategies without thinking about how we're going to study them. And there is now a lot of richness around educational research. And actually, if anything, in Africa, we need this more than ever, because with the shift to digital education, virtual education, there's not a lot of studies showing that if this is feasible, if this works in our context or not. So this has been a kind of a recent passion of mine of how we use implementation science in education. And basically, this breaks it down into a very simple way to look at it. So diffusion is letting it happen. This is the first stage of implementation science. Dissemination is helping it happen, and implementation is actually making it happen. So if you think about these 3 stages of implementation science, this is where education usually happens. Like, we help it happen, we make it happen, but we need to think about strategies and how to examine the effect of these strategies in order to document that the strategies, education strategies that we're doing right now do have an impact. So this is one of the earliest studies that we have done. I think many of you know that the work that we're doing in Sudan right now, it started during COVID-19. It's called the Community Medical Response Team. And this is the first ECHO program that we implemented in Sudan. Project ECHO is an international program for training healthcare providers. And the first ECHO program we implemented in Sudan was through the UNMC ECHO Hub in collaboration with the Sudan Federal Ministry of Health. And we delivered about 34 sessions at the time. We collaborated with SAMA at the time to send participants incentives to help them attend the sessions and pay for internet cost, because internet obviously is a major barrier for people. So we didn't have the infrastructure to do that, and SAMA had it. So they helped us to give participants incentive at the time. And we were bragging about putting Sudan on the global map, because ECHO exists in pretty much all African countries around us, but it did not exist in Sudan at the time. And this was a program that was led by youth from Sudan, which is I'm really proud of, because I'm a big believer of decolonizing global health, making people on the ground own the programs, lead the programs, and take control of it, other than people from Western countries doing that for them. And people, especially Shabab in Sudan, as you all know, are very capable of running programs themselves. They were able to topple a dictatorship. So of course they're able to run these programs. So we had them run this program for training, and then we measured the community impact. Unfortunately, we were not able to measure community outcomes, which are much more complicated. We just didn't have the funding and infrastructure to do that. But we measured what we call output, how many things were done based on this program. We trained them on COVID-19 vaccination, awareness, miscommunication, misinformation, how to engage with community effectively. We gave them the science behind COVID vaccination and COVID prevention. And then we linked them with the resources in the Ministry of Health, in isolation centers, with experts from outside of Sudan, the diaspora, etc. And based on that, was their output. They were able to treat 77 patients in home isolation. And this was a collaboration with isolation centers in Sudan. We had them refer patients that do not need to be admitted to the hospitals, because hospitals were overwhelmed. But when patients go home, there is nobody who follows up. It's not like here you say, go to your primary care doctor, obviously. So these people contacted the patient via phone on a daily basis to check on their health, check for alarming symptoms, signs or symptoms that says the patient needs to go back to the isolation center. And then they consulted with consultants, experts, specialists about what to do, because most of them were junior, either house officers, or some of them were actually medical students. They held 150 COVID-19 awareness campaigns in the community. And this was done in 6 states around the country, going to schools, going to mosque after Friday prayer, going to the market, etc., delivering these COVID vaccine awareness sessions. And they deliver 65 mobile clinics of vaccination in, again, about 6 or 7 states. And this led to delivery of 25,000 doses of COVID vaccination. And many of them tell us that the sessions that I attended were actually very instrumental in doing this, because actually the idea of the mobile clinic came from one of the sessions. We were doing COVID vaccination campaigns, awareness, etc. And one of the students came in the session and said, I'm having trouble with the community. She was working in Kober. And she said the community was very mad at me because I was talking to them about COVID vaccine, was talking to the women في صف العيش basically. And the women started like becoming angry at her, thinking she's from the Ministry of Health, saying we want to be vaccinated, but we don't have vaccine near us. We have to go to Kafuri to get vaccination. It costs 700 to take Amjad or whatever to get there. So why don't you bring the vaccine here? So we're like, oh, that's a great idea, actually. So we talked to the Ministry of Health. We talked to the Nadi Kobar al-Riyadi. We talked to Hilal al-Ahmar, and we conducted a vaccine clinic together on a Saturday. And everyone was kind of not sure if this is going to work. But at the end, there were 2,000 people who got vaccinated that day, which was a major breakthrough. And then the Ministry of Health got excited and they started collaborating with us. Shimaliya was the biggest actually collaborator, the Minister of Health there. They trained the volunteers themselves to become vaccinators. And they sent them with a vaccine, with cold chain supplies, etc., to go to other villages and vaccinate people. And through this work, we made a lot of partnership with governments, with NGOs, etc. And I love these pictures because it shows you that you don't really need a complicated system to deliver this. This is a student registering people under the tree, literally. People coming to register for vaccination. This is a student here on the top right. I love this picture لأنه مشى في قرية كان بيعملوا في vaccine campaign قبل vaccination clinic. Vaccination clinic was on Saturday. On Friday, they announced it in the mosque with microphone, using rickshaw, etc. And he went out to like basically out of his way to find people. And he found this man and just started talking to him about vaccination and that you need to come tomorrow. Explain to him what COVID is, what it does, etc., etc. And the person ended up coming. And the bottom picture here is a student going to people's houses actually to vaccinate elderly people who could not come to the vaccination clinic. So basically meeting people where they're at. From that work, the engineer group started wanting to do something similar. So they formed community engineering response team in Sudan University of Science and Technology. And they had their own ECHO in collaboration with University of New Mexico here. And we all together came together and we formed this organization called SUDRO. You might have heard me say this before, and we have several programs running through this organization. So I'm not going to go into this in details, but just wanted to show you some of the outputs from these echoes. We had a leadership and peace building echo. This was in collaboration with our organization here in the US. I really wish we had done more of this because that's what we need the most right now in Sudan. We need some peace building and to counter the hate speech that's happening right now and the racial speech that's happening right now. This program was actually very successful. It was kind of a group of physicians, engineers, talaba from different disciplines who came together and attended these sessions. And the sessions were very interesting, like, talking about leadership and conscious leadership, effective communication, peace building, etc. And the participant numbers were kind of sustained over time. Like we had an average of 82 people attending each session, and there were 8 sessions in total. And this is the output of these. People said their knowledge increased significantly after the session. And most interestingly, people said they will use what they learned in the sessions afterwards. And this was very exciting to see that it's not that they now know better about leadership and peace building, but they will use this in their communication. After the war broke, we started an ECHO called the Emergency Response ECHO. This was actually done in collaboration with the WHO Sudan office and WHO Emirates office. We delivered around 43 sessions. 23 of them were delivered by the WHO EMRO office around case management of different diseases, etc., dengue, cholera, etc., etc. We had about 2,700 attendees who attended these sessions. And there were like 80,000 people who attended or clicked on the recording. We can't say they actually viewed the whole recording, but clicked on the recording that we provided to them. And the interesting thing is that echo is usually done in Zoom, like we're doing right now. It's very different because it's case-based discussion. It's almost like bedside round. But we couldn't do Zoom because we didn't have internet in Sudan. People were not able to access Zoom. So we used Telegram, which a lot of people now use for education in Sudan. And that was extremely successful. We had a Telegram group that had 5,000 people when we started the program. By the end of the program, the Telegram group had 14,000 people. And I know many of you here, Zahir and others, actually have delivered sessions in this Telegram group. And people are very interactive. They're eager for knowledge. They're very engaged during the sessions. It's very nice to see the amount of engagement. We had other echoes since the war started. We had one on sexual reproductive health and gender-based violence. The WHO did a cholera response echo to train people on cholera response. We had a research echo, which was really surprising to me because the volunteers came and said they wanted research training. I'm like, in the middle of the war, why do you want research training? Some of them wanted it for their own purpose because they wanted to leave the country and they wanted to have something in their, CV. Some of them wanted it because they're working there and they wanted to document what they're seeing. So Dr. Saria Hassan from Emory University, Dr. Ibrahim Bani was one of the main leaders of these programs. And then we now actually conduct all the training for Sudan Medical Specialization Board because of the war, residents could not travel to Khartoum like they used to every few months to get training in different courses, being part of residence specialization. So we now switched to doing that online through our own ECHO platform. And that has been really successful. We have an echo about mental health because that was one of the biggest needs. And actually right now we have an HIV echo in collaboration with Shog. Many of you know Shog or a part of Shog. So they have led the training for that HIV echo. Now, some of the outputs that I'm really proud of is that this is not only just knowledge, but it's knowledge that is implemented. So we have mobile clinics similar to the COVID vaccine clinics that are operating in different parts of the country. Obviously, Jazeera with Jenaina have been shut down. We still have clinics in Khartoum. We have clinics in Niala. We have clinics in Kassala, Al-Bahr al-Ahmar, Northern State, River Nile. We actually now have clinics in Gadarif. And all of these are providing free services to patients from the time the patient comes in until they leave. They don't pay a single penny. Most of them are chronic disease management, but some acute cases come through diarrhea, upper respiratory infection, UTI, et cetera, et cetera. We even had some cases of gender-based violence come through as well. And we have now reached about 40,000 patients. And the nice thing about this is that there is a monitoring evaluation team right now collecting data about these clinics and what's happening and what's being seen and what's being provided. So we're hoping to put all this together in a publication in the near future because there is really no good documentation of what's happening in Sudan right now. So we need that. There are so many community intervention going on. I'm not going to spend time. And then there is so much scholarly output that came out of these echoes. Most of it is done by people in Sudan, which I'm really proud of, that they are able to present and publish. 7 presentations were done at the Meta Echo Conference. Most of them were virtual. There is one in-person presentation that was done at this IAMC conference, International Association of Medical Science Educators. The in-person one was in Minnesota. One of our students here at UNMC, she's Sudanese. She did that presentation, and then there were 3 virtual presentations from the people in Sudan at the virtual conference. I did a presentation at CUGH conference, Consortium of University for Global Health, and the APHA conference this past year. We have 2 upcoming presentations at East Africa Global Security Summit. This is a very large conference that involves all the Ministry of Health from East Africa, Africa CDC, the WHO, and other agencies. And we have 2 publications already published or accepted about the emergency response echo. One publication accepted with minor revision about the CMRT echo. And there are 2 publications now in progress about some of the other echo programs that we have done. Dr. Sari Hassan, who was one of the leaders of the research echo, helped the students put together a meta-analysis, and they're now working on submitting that for publication. So there is some really good scholarly output that came from this. It's not going without being noticed. So in the interest of time, I'm going to stop here. This is some of our future work that we're working on, especially in the HIV world. We now have a study looking at treatment disparities in patients with HIV, and we'll be presenting that at CROI in San Francisco in March. We have a study looking at HIV care and prevention during conflict. This is an ECHO training program that we talked about. We're doing a provider survey. This is in Sudan especially. And I'm working with a group in Uganda, Nigeria, Zimbabwe, Rwanda, etc. We're actually going to study, similar to the study that we did here for readiness for long-acting, we're going to do a study similar to that in Africa, which I'm really excited about that study. We're now applying for funding to see if Fogarty or other agencies will be funding this. So yeah, this is all. I'm going to stop here and just kind of wait to see if anyone has any questions.
Thank you, Linda, for the amazing review of your research. That's excellent. I'll open the floor for any questions.
Thank you, Nada, for the excellent overview of implementation science research, really. Yes, from a different angle, this type of research, implementation research, is also used widely in antimicrobial stewardship. As you know, it's all built around improvements. You've got some pieces of evidence suggest that a certain intervention may be useful in, let's say, reducing your date of therapy or reducing your mortality or readmission risk or whatever. And then it's really the bread and butter of most stewardship programs. They rely heavily on implementation research. So thank you for highlighting its importance. One thing to mention also is operational research, which is kind of sometimes used in a similar context to implementation research, but that's different, I think, in the sense that you rely on your own program data, see where you can make some efficiencies or improve your operations to attain the outcomes that you have set out to achieve. Thank you.
Thank you so much, Zahir, for pointing that out. So this is really applicable in every single field that we work in, especially in infectious diseases. Yani, we're the best field that can utilize implementation science. I didn't speak much about quality improvement, but that's really a big core aspect of implementation science. When I got into this 2 years ago, I had no clue what implementation science is or how to go about learning it. So I attended a workshop, a 2-day workshop, and that was just an eye opener. Like, it was really, really helpful. And then, it's only 2 days, so you can't learn everything in 2 days. But one of the best resources I've used, I'm going to put that in the chat, it's University of Washington. They have so many resources about implementation science. And literally, you can learn everything you need just from going through that website and their videos. And you can learn about the frameworks, how they're developed, what's the evidence behind them. It's such a rich website. The NIH, also the National Institute of Health, has a very rich resource about implementation science. So if you're interested in this, and as I said, like, a lot of this work we do every day, we just don't think about it as something that we can research and we can do science about. So I feel like we're wasting a lot of our energy not capturing that in a way that's scholarly. If you're interested, you can take just a very small educational program that you're building for your students or residents or fellows or whatever, and just think about how you can study this in a way that's very effective to demonstrate that it's effective and it's implementable. And using some of these simple frameworks, like the EPIS framework, for example, that I talked about, is a very simple framework. You start from the exploration and you end with sustainment. And you can think about what tools to study this. There are so many questionnaires out there that you can use as well. Some of them are very well explained in the website. So I would just invite people to think about, QI work and all of this stuff that they do, because that's what I was before. The work in Sudan, I honestly just did it as a volunteer service work until one of my mentors said, "You're spending a lot of time in this work. Why are you not like doing it in a scholarly way?" And I was like, oh, I didn't even think about that, honestly. And that's when I went to the department chair and the dean asked for some funding so that I can get some help and assistance to do this work and document it. And that was instrumental, because it wasn't only that I was able to document it, but I was able to fund some of the Sudanese students and resident applicants to work with me so that they can document this and take advantage of it as well. So then it's just like, if you have that science mindset, you can take advantage of a lot of this work that you do on a regular basis, whether it's stewardship, infection control, etc. Shukran, thank you everyone, and I'm more than happy to connect with anyone who needs more information or needs some mentorship or guidance when it comes to that. Yusri, welcome, go ahead.
Hello, Nada. Assalamu alaikum warahmatullah. That is just great. I'm really happy that you mentioned the word mindset at the end of the comment, because as you said, this is something that we could use in many things of what we do on daily basis. But I think you've showed us a great demonstration today that we can do things, we can improve what we do, but at the same time we can actually show others that we're doing, and hopefully improve the overall performance in whatever business that we are doing, and it could also be done even with outside medicine, isn't it? Especially now with what we have now in the upheavals in our country. So thank you very much for the demonstration, and that is really enjoyable. Thank you so much.
Thank you so much, Yusri. And I totally echo what you're saying right now about what's happening in Sudan right now, because there is so many things that are done kind of outside of the norm, so to speak, which are very creative and innovative. One of my biggest passion is the work that Lijana Tawari are doing, the emergency response rooms. And how can we document that in a way that is replicable in the future, that people know how this work started, what its impact, what's implication. And unfortunately, it's just going undocumented. And that's one of the hopes that I'm working on right now, at least finding one of these ERRs. We have a really good collaboration with Bahri, just to see how we can document their work, that they do get the reward of this work that they're doing in the future. So, but yeah, we have a very unique opportunity right now. And unfortunately, it's a disaster, but it also creates a very good opportunity for people to figure out how we can document.
Yeah, absolutely. You remember a few years ago, we had these big outbreaks of, vector-borne viruses like chikungunya and things in Kassala and Eastern region. And a lot of things were done by voluntary groups, very similar fashion to what has happened in the work that you showed with the groups that worked on the vaccine. And people were quite innovative, local people, the way they supported each other, the way they gathered fund, the way they even cooked food for families that were completely kind of knocked out by the outbreak, but there was no real documentation of what had happened for us to kind of use later on, because what happened in the last few months in Al Jazeera and in Sharq Al Jazeera, the big outbreaks of dengue fever, and we had to start all over again in a situation that is far worse than before. But even people have to reinvent the wheel all the time, because there was no huge documentation of the community response to these outbreaks in the absence of formal huge help from the authorities.
Yes, I think that's the unique thing that we have in Sudan. That's probably, we don't really capture that, the uniqueness of it, the community response and how the community comes together in these disasters. So if anyone is interested in collaborating on a project to document some of these things, please, we're looking for collaborators. The team in Sudan is always looking for mentors and people to support them. And they don't have some of the tools we have here. Just, having PubMed, for example, is something that's a luxury there. So they're always looking for mentors and collaborators. So if you're interested, please reach out to me, and I'm more than happy to connect.
Yeah, just on that point, I think part of our failure to document whatever we do in Sudan is the nature of our culture. We belong to an oral culture. We tend to talk rather than write. I think this is why it's nice to talk, but I think failure to write is kind of detrimental to us in so many ways, and also grossly unfair to the future generations.
Could not agree more, Zahir. I think you summarized everything in just like one sentence. Thank you. Okay, everyone. Well, thank you so much for your time. I really appreciate you listening, and looking forward to the next sessions, inshallah.